Greg is a very unique Master of Science in Nursing student here. Greg is also the Psychiatric and Mental Health Nurse, Deaf Unit Charge Nurse at Worcester State Hospital. And I'll let him tell you a little bit more about himself and his very unique background. So it's my pleasure to introduce Greg.
All right, as Stephanie had mentioned, my name is Greg Shuler. I'm going to be talking about challenges and innovative solutions for educating self-care skills to deaf and low literacy clients. I know that's a lot of information there, so I'm going to try to break this down a little bit more simply. Obviously, like people that have low literacy, we want to keep this as simple as we possibly can. A disclaimer that I have here, like you might see at other places, I also have a disclaimer here that I'm not representing DMH in any capacity. Even though I do work for DMH, I want to at least let you know that I'm not representing DMH in any capacity. Any comments and opinions are solely mine, and I have no financial relationships with any commercial entity at all. An introduction about myself. This is actually a picture of myself up here. I didn't design it, but I'll explain who did later. I have worked for DMH since 1993. I currently work on the deaf unit as a charge nurse, which is the only block psychiatric deaf unit in New England. I am fluent in sign language as well as English. I have also been an infection control nurse at Worcester State Hospital for about 3.5 years up until that closed. So I was actually doing 2 roles simultaneously. I was doing infection control and I was working as a charge nurse. So I also provided consultant work as a Meditech consultant for an EMR system out in Alaska, actually, which was pretty interesting. I have interest in many different areas. One of them is actually informatics. And I'm currently in school pursuing 3 different degrees simultaneously. So, doing a business degree, bachelor's degree program, as well as a nursing bachelor's degree program and a master's degree nursing program. So it's a little fun. And I also have a little one at home, so juggling everything has been fun, plus working full time. All right, my objectives today, and again, here's another picture. The sign actually means for you to understand, basically. I want to educate you about some myths and facts about deaf people. Bottom line is I want to give you some basis about deaf people itself. I can't just go straight into it without giving some type of basis or foundation. I also want to educate you on some resources that you might be able to utilize as a healthcare professional out there working with deaf patients, especially if they have low literacy issues. I also want to educate you on the term of language disfluency. Some of you know what that means. Some have absolutely no idea, but hopefully by the end of this, you might have some idea regarding what that means. I also want to educate you on the challenges that we on the deaf unit had to endure, as well as various different innovative evidence-based CBT solutions for educating self-care skills to deaf and low literacy clients. All right, as you might see there's a mountain. We endure various different challenges on the deaf unit, and that still includes today. But since we're talking about health literacy issues, I just want to focus on those type of challenges that we've been able to manage as well. So some of the things that we've noted, as I had stated, I've worked for the deaf unit for about 10 years. Some of the things that we've noted that I also had noted as well is there's been a lot of misunderstandings of deaf patients from outside resources and providers, hospitals, especially regarding literacy issues with our deaf populations. There's been a lack of use of interpreting resources out there, which includes my next piece, various different diagnoses not really matching the patient. So patient may come into us, they may be diagnosed as depressed, suicidal, having hearing voices, or whatever that is. But when we actually do an analysis or evaluation of these patients, they don't really mix. And I'll go into why that is. So anyways, to combat some of these challenges on the unit itself, we have known sign language interpreters. Actually, Sue Jones was one of our former interpreters, and we have another interpreter that will be interpreting shortly, who is currently one of our interpreters on the unit. So we have interpreters that are well-known, or basically that are qualified per the Massachusetts standards. We also have had CDIs working with us. Sometimes we've actually hired people as a freelance, on a freelance portion through Mass Commission for Deaf and Hard of Hearing, or MCDHH. So they periodically assist us with our unit's needs as well. Also, 24 hours a day, 7 days a week, 365 days a year, we have at least one or many more skilled signing staff who work with our clients and understand deaf culture and understand the unique problems that deaf patients endure, specifically low literacy patients that we have to work with. We also use innovative pictorial tools designed by the deaf unit staff, which I'm going to go over in a little bit. So a good portion of my topic is going to be basically this, but I at least want to give you a foundation and some other pieces that you need to know. All right, so I'm going to give you a foundation of deaf people itself. Bottom line is deaf people, some people think that deaf people cannot speak. Well, that is not true. Deaf people do have normal vocal cords. Some speak intelligently and clearly. Some utter only a few words or sounds. Some choose not to speak at all. Deaf people are able to communicate by other means, such as through sign language. The term deaf mute is considered very insulting. I still sometimes periodically see this listed as some of the information that's been sent over to us, referred to us from new patients that have come to our facility. I don't know why, but this continues to be an issue. Deaf people are not mute, but because they do not hear spoken language, they may not be able to speak clearly themselves. Take a moment to get some water. Deaf people cannot hear. That's a myth. Most deaf people have some residual hearing. This ranges from a limited understanding to speech to a limited identification of surrounding noises with or without the use of a hearing aid. Bottom line is, say for example, some patients cannot hear that much at all, but they can probably hear a fire engine that is coming down the street, or a fire alarm that we may have currently in this building. Actually, I see probably about 4 of them here. Another one on the other side. No two deaf persons have the same amount of hearing loss, which makes for a great individual difference between each patient. So it can be very different. So just because a deaf patient can hear or not hear, just bottom line is you need to get to the patient's level as best as you possibly can. Hearing aids make a deaf person hear. Some people just say, here, put on a hearing aid, put it right on, and then you can understand what I'm saying. Well, not necessarily true. Hearing aid amplifies sounds, but its effectiveness depends on the wearer's ability to discriminate between speech and sounds into the brain. Not all deaf persons can benefit from a hearing aid itself. Deaf people can lip read everything that is said. That's not true. So when you basically try to slow down and say, can you hear me? And you kind of speak very loudly, probably not the best thing to do. I'll explain what you need to do, but anyways, the best, just to provide some information here, the best lip readers in a one-to-one situation were found to understand only 26% of what was said. So think of that. That's only 1/4 of the amount of what you say. They can maybe understand what you're saying. Lip reading. Sometimes by context, they get the full sentence. And 40 to 60% of the words visible on the lips look alike. For example, the sign, when you say, I love you, it looks like elephant juice. So you really don't know what you're saying sometimes to a deaf person. Deafness is just a loss of hearing, another myth. The biggest problem with deafness is being cut off from the normal means of developing and understanding language and communication. As Helen Keller had once said, being blind cuts one off from the world of things, but being deaf cuts one off from the world of people. Another myth. Deaf people have lower intelligence than hearing people. Well, some people think that. Research has proven that the basic intelligence of deaf people is comparable to that of normal hearing populations. For example, there are many people that are deaf who hold bachelor's degrees, master's degrees, and doctoral degrees out there. Another myth is sign language interpreters is the answer. This person right here. Well, sign language interpreters are not the only solution to solve the communication barriers between deaf and hearing people. They're the process, but not the solution. There's also certified deaf interpreters, which I'm going to explain who they are or what they are, who also work alongside with interpreters and can help facilitate the communication process. Not necessarily a remedy of the problem either. So even if you have an interpreter and you have a CDI, sometimes it's just not enough, specifically if you're dealing with a low literacy person. Another myth is taking an ASL class means I can communicate with deaf people. So you take one class, you're done. Now I can fully communicate to everybody out there. You know, the funny thing is, at my facility, not currently, I haven't seen that per se, but in the past what I've seen is some people, they proactively go out there and try to learn sign language, maybe take a class, and then they say, I'm now a signer, I can now work on the deaf unit. No, not really. I mean, they still can't even communicate really simple things with our patients. The bottom line is, to communicate with deaf people fluently and culturally accurately, it takes more than just 2 years of college ASL classes. It's actually a lifetime commitment. Similar to speaking English. I wouldn't expect, probably some of you probably go take Spanish, French, or some other language out there and say, hey, now I can communicate to anybody out there that speaks whatever that language is. American Sign Language, what is that? Some people probably have heard that, I hope so. It's also known as ASL. It's a visual language used by deaf and hard of hearing people in North America. The key word is in North America. So, same thing with France, same thing with all these other countries out there, they have their own various different dialects as well. Sign language, or ASL, is only specific to North America, specifically the United States. This is a language that contains phonology, morphology, semantics, syntax, pragmatics, just like any spoken language. But it is not a written language. It is not based on English. Please understand that. It is not based on English at all. It is not broken English. It is not summarized English. And it is not bad English either. A variation of this is signed exact English, pigeon sign English. These are examples of a communication mode, but they are not languages. So these are some variations of sign language that we use. Sign language interpreter. These people facilitate communication between English and ASL, or they transliterate for deaf or hard of hearing people. These people are fluent in English, and they're also fluent in American Sign Language, which combines signing, finger spelling, and specific body language. Some specialize in oral interpreting and lip read instead of signing. Other specialties include tactile signing, which is actually speaking into someone's hand. So this is in regards to someone who's deaf and blind simultaneously. We've had some patients that have come to us onto our unit in the past that we've had to do this with some of our patients, where they can actually sign into their hands. It takes an enormous amount of time to work with some of these clients. Assumptions of interpreters. Having an interpreter resolves all communication needs. Not true. The reality is, many deaf people have limited language skills and cannot make good use of interpreters. For example, all right, so say I work in the psychiatric field, so let's say you ask a patient a question, let's say, do you have hallucinations? Let's say, do you have auditory hallucinations? So if you probably have someone maybe not as skilled as an interpreter, maybe you do, maybe you don't, or maybe the person who's asking these questions maybe is not the most skillful person as well. So sometimes when you try to ask these questions to patients, so it goes from me to the interpreter to the patient, and sometimes there's a problem in that process where there's a sending and receiving process. So a patient may not understand what auditory hallucinations mean. So a sign may be like this, you understand auditory hallucinations. Bottom line is, there's an assumption. You can't just assume that everything that you're saying to the interpreter is being informed to the patient exactly, perfectly to what you think in your brain. And you need to understand that. Specifically, if the patient has no idea what you're talking about. Why is this the case? Well, sometimes it's because interpreters also sign in an English-like modality. Again, like I mentioned earlier, ASL is not English. It's its own various different language. Certified deaf interpreter. Who is that? This is a person that is deaf, that is hard of hearing, possibly. These are people that take interpreting training programs like a sign language interpreter. They are language specialists. They work side by side with a sign language interpreter generally. They understand ASL and they are visual gesture savvy. Basically, they can be able to get to the level of patient, specifically someone who has low literacy issues. They specifically help work with foreigners, deaf blind people, children, people who have mental illness, people who have developmental disabled issues, or, like in this situation, help literacy issues, they're language deprived, or they have some cognitive impairment itself. There's another resource that you can utilize out there. I know Fred had mentioned about a phone that you can just call right up and you can get any interpreter service out there. Let's say if you need someone that speaks Farsi or some other language out there. Well, there is a variation of that so that you can go on the internet, for example, and you can utilize something called video remote interpreting. It can be called various different things, or interpreter, internet interpreting services, whatever that is. Each service has its own name, I suppose. This is probably something that's could be utilized 24 hours a day, 7 days a week. However, I do want to caution you. There's problems with this, though. It has uses, but there's also problems as well. For example, not all interpreters are certified. Interpreters generally are from some other state, not within the Massachusetts area. And often there's misinterpretations because what we know in Massachusetts, because, you know, similar to, say, the South or in the western part of the United States, they have their own dialect and language and so forth. Let's say some people say a hoagie or submarine. Well, it's the same context for sign language as well. So, and there's problems. So if a patient doesn't understand what you're saying, and you're using an interpreter that is based upon someone that's out in California, and they're using a sign that's familiar with the area in California, but not based on Massachusetts lingo, it could mean the difference between a lawsuit for you guys, specifically if you have something that's very critical and you're asking a patient a question. So you might want to think about that the next time you use a service that's out there. Anyways, you can use a system similar to what Fred had mentioned. This system should be used only if there's no other resource available. Specifically, let's say you have a family member that's willing to interpret for you. I wouldn't recommend that person to help, or a friend of this person that's coming in, say to an emergency room. These people are not neutral entities, and they've never gone through, probably they have not gone through any training formally. Mass Commission for Deaf and Hard of Hearing. This is another resource that's out there for you. Actually, for me to get interpreters to come here, I actually utilized MCDHH to be able to have this as a resource for us here at this facility. Who are they? Well, this is another state agency that's available out there. What do they do? They provide communication access, training, technology services. They also provide case management services. They provide interpreters, for example. They also provide CART, which is communication access, real-time translation, referral services, and they also provide independent living services for deaf and hard of hearing people. What I recommend that you do is go onto the website listed here. For those of you who probably can't see that, it's www.mass.gov/MCDHH. I also provide another piece that's part of this as well from MCDHH. From the census of 2000, I know that we just had a census just recently. I don't have that information. It wasn't on the website. But it estimated that people 3 years of age and older was about over 6 million people in Massachusetts alone. It was estimated the number of deaf and hard of hearing people was about 500,000 people. Yes, not all of those deaf people or hard of hearing people know sign language, but there's a good portion of those people that do have some familiarity regarding sign language. But anyways, that population is about almost 9% of the population. The deaf unit, where I work, Worcester State Hospital. Some of you have never heard of this place. And that's partially because we work for a non-profit organization, and to publicize ourselves is kind of hard to do. Anyways, we are a culturally affirmative, deaf-friendly signing environment, working with psychiatric patients. These patients are adolescents. These patients are also adults. It's a mixture of the two. 14 years of age up. We serve deaf and hard of hearing populations dealing with mental illness, and we are the only locked psychiatric deaf unit in New England. The deaf unit staff use sign language to communicate with patients, and we have a high percentage of our patients that come into us with language disfluency. Again, I will explain what that means, but it's based upon literacy issues. As of actually April 1st this year, April Fool's Day, and it's not a joke, it's an actual thing. We now are listed on the website. After all these years, we were never listed on the website, but if you go on mass.gov, just like when you look at MCDHH, we are listed there. If you go into mass.gov, I believe if you just put in there deaf units under the search item that's listed up here, I believe this will pop up, and you can it provides you more information about us, the deaf units. There's a brochure there that you can go into as a link. Actually, the website is also listed below here, just in case you're interested. It also provides a deaf unit referral form for those of you that may be interested in actually referring patients to us. Bear in mind that's because we are the only locked psychiatric deaf unit in New England. Sometimes we are full census, and we may not be able to provide assistance for every deaf patient out there. Members of the deaf unit team, who are they? Well, we have the communication department, sign language interpreters, communication specialist, psychiatry, medical staff, psychologist. We have an RN like myself, and nursing staff, social worker. We have rehab staff, who includes an OT person and a rehab counselor. We have other members of the team, but this is basically the core team that we have. I mean, we have dietary and other various different disciplines as well. Not that they don't mean anything, they do mean stuff, but these are the team members that actually make decisions based upon what we need to do for our patients. Anyways, another thing that I'd like to do is, for anyone that's out there from the deaf unit, formally or currently, I'd like to just at least provide that is currently here, and there's probably a few people here. I want to at least provide a warm welcome for some of those people that are here. So if you don't mind clapping, but actually doing a deaf clap. So I want to teach you a little bit of sign language here. So language disfluency. Heard me say this a few times. What does that mean? Well, it means language deprivation of deaf people. It also is relevant to hearing people as well. So I want to at least make that known. So, but since we're focusing on deaf patients here. So it means language deprivation of deaf people due to a lack of adequate exposure to sign language throughout their lifetime. So they had no exposure at all for sign language throughout their lifetime. And they never somehow acquired the native fluency for any language at all. It is not always due to a cognitive functioning level or thought disorder. They could actually be pretty intelligent, but they just never had access to information to learn a language. Many deaf people are not fluent users in sign language, but that does not mean that their language is fluent. But bottom line is, language, for someone who has language disfluences, it means that language is impaired or language is disfluent in their best language. For example, for deaf people, ASL. I have a picture here. You're probably wondering, what does that mean? Well, I try to put it up here as someone who may think that they're lost in the dark. So you see two little eyes up there in the dark. Well, that's how a lot of deaf people, or maybe people who have language disfluency, they may feel. They feel like they're lost in the dark because they can't communicate with any of us. Characteristics of deaf people with language disfluency. They have problems with education, social skills, vocational skills. They also have problems with independent living skills. Also with this picture here, person that has a question mark over their head, basically it's someone speaking gibberish. They have no idea, this person has no idea what's going on. It could be speaking, could be in sign language. They just have no idea what's going on. So that's basically it in a nutshell. They just don't have an understanding. And it's how do you work with someone like that? It can be very difficult. Well, how do you? Well, anyways, on the deaf units, we have developed various different tools to basically help combat language disfluency itself. Some of these tools are innovative evidence-based CBTs, that means cognitive behavioral therapy solutions for educating self-care skills to deaf and low literacy clients. And this also includes over, I know Ben had mentioned over 1,000 pictures, but actually we've developed up to 3,000 pictures over that. On, no, that's okay, Ben. Over 3,000 pictorial communication tools designed on the deaf unit alone to work with some of these patients. That helps. Just gonna be able to have the interpreters flip over here. The key pioneers of these pictorial tools, number one is Dr. Neil Glickman. Mikey Kranak is the other person, and the rest of the deaf unit team. I mean, it encompasses everybody, but I just wanted to mention the first two, and I'll explain why. Dr. Neil Glickman is a former unit director of the deaf unit itself. He has a lot to do with why we did what we did for these pictorial tools. He's also a world-renowned psychologist that specializes with working with the deaf population. His website is listed above if anyone's interested. You can also just do a Google search in case you don't have this presentation with you at the moment. You just put in there Neil Glickman. Anyways, this is a pictorial version of him, just like there was a pictorial version of me earlier. This is his work, one of his most recent books. He's done a lot of work, but this is one of his most recent books. And actually, if anyone's interested, some of those pictures that I'm going to go over is actually listed in this book, but not all the pictures. Mikey Kranak, who is he? Well, he is the former communication specialist of the deaf unit. He is actually the artist of all these pictures that you see, or actually most of these pictures, not all of them, because there's a few in the beginning that he did not design. I actually incorporated those in there. But he's also a CDI. What does that mean again? Certified Deaf Interpreter. Because I work in the psychiatric field, I want to at least, when I go into these pictures, because that's what I'm going to do right now, I'm going to go straight into these pictures. I want to at least first start off into the psychiatric realm first, and then go a little bit further. So, here we have depression. This is a list of various different tools that we use to actually, as I mentioned earlier, sometimes patients come to us and we have to evaluate whether they actually have depression or not. Well, this is one of our tools, not the only tool, but one of our tools that we work with our patients that have low literacy issues. I understand you probably see words on there, but that's okay. They may not understand those words, but this is for a staff member to sit down with the patient and try to explain what all of these different symptoms of depression are and work with the patient. So sometimes it's working with an interpreter, sometimes it's working with a CDI, communication specialist, whomever that is, as well as who's the person that's actually interviewing the patient. Could be a psychologist, could be a social worker, could be a rehab therapist, could be a nurse, or other people as well. So I'm not going to go through each one of these, but I just want to give you a flavor of some of the tools that we use here. So this is depression, fear, or anxiety disorders itself. This is another pictorial tool that we use as a check-off to see if they may have fear regarding something. These are not all the pictures, but this is just to give you a flavor for what that means. Mania. So some of the people that may have bipolar disorder, for example, well, we want to see, maybe, do they have any mania? So here are some pictures here that we have to work with our patients. And it's not just a one-time thing. Sometimes we work with the patients more frequently than that as well. Oh, missing slide. Anyways, once we come to a conclusion of whatever that diagnosis is, we want to at least educate what the patient has with that patient. I'm missing a slide. Sorry about that. Technical problem. Anyways, there's one picture missing from here, but that's okay. Anyways, this is antisocial personality disorder. These are just a few pictures. These are not all the pictures that we work with our patients. So in this slide here, you have someone that punches somebody else. And the bottom line is we want to come to a conclusion that they may have no remorse for whatever they're doing. They may be in trouble with the law, caught by the police, for example, or some of you are familiar with maybe Pinocchio. They have a long nose, so some patients may understand this. So we basically have to get to the level of the patient, and we have to tailor some of our pictures based upon each patient. So in this situation, are they telling a lie? So once we come up with a diagnosis and we work with our patients, a lot of the things that we work with our patients are skill-based treatment modalities. So number one is coping skills, which is an inability to manage your own internal feelings. So one of the key sources here is, you're seeing a traffic light here. You're probably wondering, what does that mean? Some of you probably have seen this before, maybe utilized. Some of you have absolutely no idea what I'm talking about. That's okay. I'm going to try to break this down as quickly as I can and as simply as I can for you. So most people out there drive, I assume, I hope. So some people don't, but basically most people are familiar with what a traffic light is. So patient may be escalating, for example. Let me use this as an example. So a patient may be escalating. You're noticing that they have issues, and some of their issues, key issues, is maybe they have anger, they blow up, and so forth. Well, the biggest thing is we try to coach and educate patients to at least acknowledge, stop and notice what they're doing. And hopefully we get to the point that they may actually understand without us actually coaching them into that level. But it takes several steps to work with our patients. Some may never get to this level, but we hope that they can get to this level. So number one is the red light. They want to at least stop and notice before they blow up. Hopefully they can take themselves out of the environment, maybe help themselves calm down, which is the yellow there. And then the green is, well, hopefully they have calmed down and they can actually think about how to approach that situation and act differently. This is no different than you or I. I mean, all of us need to utilize coping skills. This is not just for the psychiatric patient out there. But this is also for patients out there that have low literacy issues as well. This is another variation of this, stop, notice, feel. I'm not going to go through all this, but these are some other coping skills that we use. Unfortunately, there's two missing here. I don't know where they disappeared from. Probably some technical difficulty. But anyways, these are some coping skills. There's some deep breathing. There's showering. You see someone that has something locked in a box. This is a metaphor that we use sometimes with our patients. Hopefully they can understand this. So you have a problem, put it in a box, lock it, and put it away, and you have no more problem. And stop thinking about it, basically. Or the other one that I like is have a balloon. So think of your problem as this balloon. So what do balloons usually do? They float in the air if you let go. Well, if you cut them off forever, they are gone. So this is another coping skill that we work with our patients. Meditation is another one. Jigsaw puzzles. I know one of those that's missing is video games. That sometimes is helpful. Ripping up paper sometimes is helpful for some of those low literacy patients, which is not there. It should be here. The other one is I can. This is a picture of I can. This is basically meaning positive self-talk. Hopefully patients can get to that level. So basically they can try to coach themselves internally to think that they can actually work through things. Another variation of coping skills is sensory modulation integration, SMI. A lot of our rehabilitation staff understand what this means. They use this a lot with our patients. It's basically using the 5 senses as well as movement. So understand, you've got a picture here, birds chirping. You're probably wondering, why do we even have a picture of this with our deaf patients? Again, some of our patients can hear at different levels. So some of them can actually hear music, possibly. And some other variations, scented candles, that could be considered aromatherapy. Or maybe some of you are familiar with colors, color therapy, or various different visual aids as well. Taste, one of the pictures that's missing from here, again, I'm missing pictures, I don't know why, but petting a dog. So pet therapy is another variation there. So just basically the 5 senses. And like I said, movement. What does that mean? Exercise. So exercise is probably, is a good coping skill. Some of you feel really good afterwards. Some of you don't even have the energy to do that exercise, but that's okay. I don't have the energy at the moment. Like I said, I'm doing 3 degrees and other things, but trying to get there myself. Hopefully I can educate the patients as well to do the same. But some of these variations are here. Sit-ups, taking a walk, using a trampoline, and other different techniques as well. So this is that was another pictorial version that we used. Social skills. So coping skills was an inability to manage your internal feelings. Now social skills means an inability to manage everybody else outside you, basically. So you have some social skill pictures here. A couple are missing again. Apologize for that. So the first one is accept skills. So let's say I'm a staff, I educate a patient, I'm sorry I can't help you right now, I know you want me to assist you. Hopefully we can get them to be patient and wait for staff to be available. Hopefully they can get to the accept skills, that they can be able to do that. Some of our patients have never gotten there, probably will never get there to that level, but we try to help them. Speaking of help, hopefully they can use help skills. They can help somebody else out. Practice skills. Practice their social skills. Another one. One that's missing there is say sorry skills. Another one, positive self-talk. I can do it. I can help somebody else out, and so forth. So once they have social skills and coping skills, hopefully they can get to the next level, which is conflict resolution skills, which is a little bit more advanced for some of our clients, but some of them can get to that level. So like in this picture here, you got 2 patients fighting over, let's say, a TV remotes, because they want to watch the same TV, because we only have one TV. Whatever the conflict is for each patient, could be different. So they're arguing about that. Hopefully we can get them to use the red, yellow, green, and they can stop and notice, hey, I'm doing something wrong. Hopefully they can work together and brainstorm ideas that come to a resolution out of this. Missing another slide, sorry. But anyways, the bottom line is you want to get to the next level of a win-win solution, so that way everybody's happy. Or as Neil used to say, win-win-win. So let's say I'm one of the patients, there's another patient. So both of us wins, that's 2 wins, and then the other one is everybody wins. So it kind of it expands exponentially. Relapse prevention skills. Some of our patients have dual diagnosis issues. Some of them have relapse prevention problems that are related to not just drugs and alcohol. Sometimes it's related to anger management. Sometimes it's related to sexual issues. Whatever the issue is. I just put up here just some pictures that are just based upon drugs and alcohol and cigarette smoking, for those of you who are trying to quit smoking as well. Anyways, we have pictures out there that we work with our patients to manage those issues. Poor ADL skills. Unfortunately, I'm missing a few more slides that were helpful. Well, anyways, bottom line is, some of these pictures, and I try to be as nice about this as I possibly can with some of these pictures. Some of these are pretty graphic, and I understand if you were to see the CD or if you ever see some of these pictures, the reason is you need to get to the level of the patient. If you can't communicate whatever that means to the patient, they're not going to understand you, specifically if you're working with the deaf population. So sometimes you may see some pretty graphic pictures. I don't have any graphic pictures per se here. You might see a few things here, but they're not as graphic as some of the other ones, because you need to be, with deaf culture, you need to be very blunt, basically. But in these pictures, poor ADLs, a lot of our clients that come into our population have really poor ADL skills. Not all of them, but a good portion of them. So maybe their clothes smell, you can see flies coming off them. There's another picture here, they look disheveled. Another picture here that's missing, which was pretty nice, it was about bad breath. And there was another one about their environment being not clean as well. You saw flies coming off their clothes and their environments as well. Another one was, we hopefully get to the next level, which is good ADL skills, which hopefully they can shower, hopefully they can shave, hopefully they can brush their teeth, but not all of them can. Hopefully they have good infection control practices, especially when they're spreading diseases, possibly, using soap and water, combing their hair, washing their clothes. Another one that's missing here is cleaning their environments, which is a critical one as well. That's unfortunate. I don't have a picture for this one.
Not your handouts, though.
Anyways, I'll explain the story. We have an ADL. I have an ADL story with a patient that had. He came to us. Let's say I'm just going to use his. Let's say his name is Bob and his sign name is B like this for the interpreter. All right. Anyways, he came to us in his 40s. I don't remember exactly his age, but let's say he was in his 40s. He at one point in time was unaware how to use a toilet to defecate, basically. All right. So, anyways, he came to us. I don't remember the exact reasons why, but he came to us. He was unable to defecate using a toilet appropriately. So what was he doing? He was defecating in his underwear, in his pants, and so forth. And it got to the point, and I'm sorry to be graphic here, it came out of his pants periodically. So initially, when he came to us, some of the members of the team said, well, we can just give him a diaper and we'd be done with it. And then we refer him to maybe to a nursing facility and so forth. And a lot of people said, whoa, 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 hold on. We need to work with this patient. Get down to the level of the patient. Again, another important key element here is he had low literacy. He basically didn't really have a language, and we needed to work with him. And we had to go step by step by step with this patient. So there was a picture here with him being soiled in his pants. Well, we needed to, and I'm not going to go through every different step, but one of the pictures that were the next step was we needed to educate him to actually take his underwear, actually go into the bathroom first, and then go to the toilet, and then release the defecation into the toilet, and maybe even dump it into the toilet to at least get rid of the rest of it, and then take the underwear and put it into a containment and laundry bag, and then it would be sent over to laundry to be managed. Anyways, to not go through all the different steps in this process, it took about a year and a half or longer. I don't remember the exact time frame. It was a success story. We were able to re-educate that patient to remember how to use a toilet appropriately, to the point that he was able to be then referred to a group home where he needed to go to, which was the most appropriate placement for that patient, which we felt. And we didn't want to put him in an inappropriate placement. So he's been probably gone from us probably about a year to 2 years. I don't remember the time frame. He has not been referred back. and they do know we exist. The agency does know that we exist. So the bottom line is it was a successful story for the deaf unit. Some of the nursing staff, some key members of the nursing staff took a lot of time and effort working with him. All right, so I'm going to go into some medical rules and medical pictures here as well. So, all right, so you have a patient that comes into you that's deaf and may not understand sign language or other things, so you may need to use some pictorial tools. And they need to see somebody, say a doctor, for example, but you can't just jump them into a situation without first introducing what you're going to do. So you may want to show a picture of, hey, a doctor is going to see you, or a nurse is going to see you, which is one of those signs. Or another one is, you're going to have some blood work. That's a frightening thing for someone who doesn't know what's going on and someone's jabbing you with a needle. Not a good thing. So you need to try to educate to the level of the patient as best as you possibly can. Some pictures missing here, but I'll explain. There are pictures here that if you're a nurse, some of you are here in this environment, you might want to do things, let's say temperature, pulse, respiration, blood pressure, and weights. Well, we have pictures here that we work with our patients because even this can be frightening for our patients. Allergies. Some of the pictures that we work with our patients, do they have a bee allergy, egg allergy, seafood allergy? There was one that's missing here, it's nut allergy. Anyways, bottom line is, there's different types of allergies out there, and asking a patient, do you have an allergy, is probably a very critical thing, I would assume, right? Probably. That'll be probably one of your number one things. Do you have any allergy? And trying to explain, so if you ask them, do you have an allergy? They may not even understand this sign of what that means. So they may think, they may think of it as, I don't like something, like I don't like milk. Or, I've asked patients these questions, and I realized later, it's not that they have an allergy, they just dislike whatever that is. And even simple translations can be misunderstood as well. I apologize, there's another picture missing, but anyways, I had a listing of pictures. The typical things that you would ask a patient. Do you have a rash? Do you feel swollen? Do you have difficulty breathing? There were various different pictures based upon this for each allergy thing. It was also, what was the number one thing? Do you have an allergy to medication? Side effect pictures. So, patient is on a medication. You might want to know, gee, do you have any side effects? How do you ask that patient something like that? Sometimes it can be difficult, so one of them that's missing is, do you have constipation? So, the next one that you see there is, do you have diarrhea? Do you have a headache? Do you have a fever? Do you have a rash or itchiness? Do you have nausea? Do you have vomiting? Do you have weight gain, weight loss, whatever it is? Whatever the different side effect is, we have multiple different pictures that we've utilized with our patients. Routes of medication. Well, educating patients about medications is probably one of the key things that you might want to do as a nurse or some other healthcare profession out there. So, with a low literacy person, you might need to educate them that, hey, you're going to get something in your eye. I'm sure that, if you start introducing something into their eye, they may go, whoa, whoa, what are you doing? Whoa, stay away from me. So, you might want to show them a picture of, hey, guess what? You're going to have something in your eye. You might get a shot, too. I don't know. I mean, that might be something you might want to educate your patient. Or you need to do an inhaler. Or you might get a peel medication, whatever that is. Some of the things, you got to get to the basic level of the patient. Sometimes we need to educate them about medical problems, say diabetes. So we have various different educational tools that we use with our patients about that. There are some pictures here. Tuberculosis, which is missing. That means you don't have any tuberculosis. You're clear. Anyways, so sometimes we need to educate them about tuberculosis being a problem. Conjunctivitis.
No, that's fair.
You could also use this for drug use too. So you got some red eyes there and so forth. So you need to educate them, again, on the basic level what some of these things are. thyroid thrum, again another missing picture. But anyways, it was a picture of showing what the thyroid looked like itself. Dialysis. So if you're going to send a patient to dialysis and they're going, I don't want to go there. There's some scary machine. I don't know what's going on there. So we came up. We had one patient that needed to eventually go to dialysis. So we need to kind of come up with something like that. And basically, we need to explain to them that we're washing their blood. So we're trying to help them wash their blood. Medical symptoms. So let's say a patient comes to you and like, oh, I got a problem, and you try to figure out what's going on with that patient. So maybe the first thing is, hey, I got a heart attack. My chest is hurting. For some nurses or some MHW or mental health workers that I work with, they may not understand what's going on with the patient, and that can be a very critical thing. So I mean, and I'm not trying to be joking about this, but someone may say, well, would you like fries with that? I mean, if you don't know what's going on with the patient, it can be the difference between a life-saving situation or not. So a few other pictures here is, did you fall down? One picture that's missing is, were you incontinent at nighttime? One of the pictures that's listed here is, sometimes you need to educate them about what's going on inside their blood. So they may have some type of infection, they have a fever, whatever that's going on. So you need to, or maybe they have HIV, I don't know. So you need to educate them that you have white blood cells that are fighting off whatever that is inside their blood. Pain scale. Some of you are pretty familiar with what a pain scale is and so forth. Anyways, on the deaf unit we came up with our own variation of that, but it's basically to mirror what you've already seen that's out there anyways, but using what works for us and our patient population. Some of you may want to know more about sign language classes itself. Well, here are some resources here. There's about 5 in total here. There's a learning center for deaf children out in Framingham. That would be the one that I would probably, because I know it, I would strongly recommend that one out to you. Not that I would not recommend you to go into a college or some other facility out there, but I would strongly recommend that you probably go to a place where they have a deaf person teaching the language itself. Sometimes in a college type setting they may not have a deaf person teaching it. Maybe they will, maybe they won't. But from all the years that I've been involved in the deaf culture, deaf population itself, this is the #1 thing. If you want to learn the language, you want to learn it from someone that's deaf. And you don't want to just go through the motions, basically. So, basically, a few things that I'll explain is they'll tell you to turn off your voice so you can't talk. You can talk, but you have to sign it. So, you can communicate all you want in the classroom, but you can't use your voice. So, and that's a key element in that process. But in this program, not that I'm saying you need to go there, but I went there. It was a 10-week course. I believe they still do the program itself, 1 day a week. It's actually a school for the deaf for elementary and high school people during the day, and at nighttime, if you want to learn sign language, you can do it. I believe it's 4 or 5 times during the year that they do this. Other resources, Deafwood Foundation, website is listed there. MCDHH, also I provided that website earlier. Registry of Interpreters for the Deaf, www.rid.org. Or Ask a Deaf Person. That is probably your #1 resource right there, is asking a deaf person. Other resources are the University of Rochester Deaf Wellness Center. The other picture is missing from here, but anyways, it's the AHRQ Healthcare Deaf Community Health Worker. That's another research. So I would just do a Google search on that to get the website. Before I ask any questions, I will provide you my contact information. If anyone wants to ask me any questions after this point, in case you missed something. But anyways, is there any questions that you would like to know about me or the program or anything else about deaf culture? Although I'm not an expert, I feel like I am pretty proficient in the area, and I feel like I could assist any questions.
So Greg, I'm in a concrete mode right now, so if I come into your unit and I'm depressed and you need to assess me,
Yes.
and I'm deaf, are your pictorial cards on a deck of cards, or how do you actually go about that with the assessment using your cards?
No, that's definitely a good question. So first thing is, like any other patient that comes in, first of all, we need to determine, we have to, like any other patient, we have to do an evaluation by nursing, psychiatry, social work, psychology, on and on and on. Once we come to a conclusion that you need more education than just using an interpreter, using a CDI or a communication specialist, we then, as a team, decide how we can approach you as best as we can. We would definitely utilize our communication departments, our interpreters, our communication specialists, as well as various different sign language, sign language staff that we have are already hired on staff. Usually it's our nursing staff who would basically be able to try to figure out and analyze what might work for you, for example. So let's say you're a low literacy person, you may not understand to that level. We then have to try to figure out how can we work with that person, say it's you, for example. So then we may then decide we need to go strictly right into specific targeted pictures that will work for you. Because not every picture is going to work for every person, because every person is an individual, and you being your own individual, we have to work with what works for you, because this is not a perfect science. Psychiatry is not a perfect science, but even working with a language is not a perfect science, which I'm sure Beth and Fred can probably explain as well. But we would have to get to that level, and then once we figure out that thing, we would have to go through the pictures that we have already on staff, and sometimes we would have to come up with our own variation of that. So hopefully that explains your question.
So the assessment team actually determines which method and which cards will be used for the client.
Correct. It will be the actual, the whole deaf unit team as a whole that will work together. And this like anything in the nursing psychiatric field, it's an ever-growing, you don't have a perfect thing right away, so you have to kind of, as time goes on, you have to build upon what you know, what works, what doesn't work, and so forth, to try to get to the level of that patient.
Just several things. One, pictures besides plain language is a health literacy practice. It's one of the best health literacy practice. It's pictures. Second thing is those 3,000 pictures are available in a CD in the book. I know we actually do have the book here. I'm not trying to sell it, but
yeah, we're not trying to sell it, but because I cannot give you those pictures. I unfortunately can't. But there are a good portion of those pictures are actually on Dr. Neil Glickman's book here in the back.
And the third question is, do you foresee us as nurses using like iPad or Kindle with those pictures and in the clinic with our patients?
Certainly. From my slight expertise, I'm not an expert, but my area with doing nursing informatics, I would say definitely. I think using some way that you can actually transport something easily accessible to a patient as quickly as you can to basically get to the level of the patient, whether that be using a Kindle, an iPad, or some other technology out there. Certainly, I would definitely utilize any resource out there, because how can you actually bring that computer, like in this situation, how can you bring that computer? It's like, hey, come on over here, because sometimes you can't always work in just that little isolated spot. You need to get to the level of the patient. So in my setting, working with psychiatric patients, sometimes you have to go to the room itself. Sometimes you have to go off the unit. You don't have that resource.
Right. So one of the problems with health literacy in the real world is that we do not have time, especially at discharge and in the clinic. We don't have time as practitioners. So anything that can help us to do that is great. So it's wonderful work.
Thank you very much, Greg. That was fabulous. It was this symposium we hope has helped you to take health literacy from a fundamental understanding of the picture here in central Massachusetts to an actual clinical application of this new knowledge. I also would encourage you, we have refreshments outside. We'd like to invite you to stay and network and meet each other. We have students here from the Master of Science in Nursing program. We have faculty from Worcester State University. We have a faculty member from the University of Massachusetts at Worcester, the Graduate School of Nursing, and somebody from AHEC. We have lots of resources, so we encourage you not to leave without meeting some other people that are doing work in this field, and we hope that we can all move forward together. Thank you very much, everybody.